Good afternoon. I'd like to welcome and introduce Dr. Robert Murphy, Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine, who answers your COVID questions every Wednesday on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be answering viewer-submitted questions and addressing the latest COVID headlines for February 8th. We invite you to submit your questions via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. And leading the discussion today is myself, Sophie Bukowski, a student research assistant with the Institute. So Dr. Murphy, I'm going to start with some updated COVID statistics.
Great. Thank you, Sophie.
In the United States yesterday, we saw 31,892 positive new cases with a 7-day average at about 39,460 cases. We are seeing a 14% decrease over the last 7 days. Hospitalizations have decreased by 18%. Deaths have decreased also by 17%. Illinois is not recording daily, but the last that they recorded was on February 2nd, where they had 9,998 new cases. Hospitalizations are decreasing in Illinois by 28%, and the death rate is also decreasing in Illinois by 27%. Dr. Murphy, I know we're going to get into this a little bit more later, about hospitalizations, et cetera, but these numbers seem to be very positive. Should we be excited about this?
Yes. The winter wave is ending, or it's beginning to end. And all the numbers are going down. The only ones you can really count on, to be honest, is the hospitalization and the death rate. Because most people are being diagnosed at home, and that doesn't get reported anywhere. So there may be a lot more cases, but there's a lot less hospitalizations. And so why is that? 3 things: vaccination, prior COVID, and the use of Paxlovid, the drug. So all those 3 things. So we have developed somewhat of a herd immunity that's keeping this thing really suppressed after this winter wave. So let's hope it just keeps going in this direction. Keep in mind, though, we still have 453 deaths approximately per day on average. So that's still up from the low 300s. But death is the last metric to change. So I would expect if we're going to see that change, it's going to be sometime during February.
Yeah, absolutely. And you talked about Paxlovid just now. Our first big headline is, what should senior citizens know about taking Paxlovid and how that is affecting the situation right now in the US?
Well, Paxlovid actually has 2 drugs in it. And one of them is called ritonavir. And that's a drug that it was used as an antiviral agent in HIV, but it's used at a very low dose. But the reason why it's used, it blocks the metabolism of the other component of the other drug in the combo. And so you get an effective level. So we call it a pharmacologic booster. It's not a vaccine, it's a pharmacologic booster. And that's really critical in many of the HIV drugs and also in Paxlovid. So, it just that little bit of ritonavir in there just makes the levels go high. But unfortunately, it's going to make the levels of a lot of other drugs that people could be taking go high. Right. So you have to really discuss, there's so many different drugs out there. It's hard for us to talk about it here. But anybody who's on any other drug, before you start taking Paxlovid, have a discussion with your doctor. If you can't get a hold of the doctor, have the discussion with the pharmacist. They've got lists on the drug interactions. Now, in many cases, you can, if there's a bad reaction, you can stop your medicine for a few days while you take this. This is only for 5 days. And then once you stop taking it, that effect goes away. So there's very few absolute contraindications. There's a lot of minor ones, but most people can get through this. So, but you just have to be a little careful. These are powerful drugs.
Yeah, no, absolutely. And then going into our second COVID headline, Dr. Murphy, is that the New York City is going to end the vaccine mandate for city workers this week. Can you tell us about the controversial mandate that occurred during the pandemic?
Yeah, this is happening all over the place now. So, the military had an act of Congress to pass the last budget thing with all the military money in it. The White House had to agree to drop the mandate in the military. Now they have to take like 10 or 15 other vaccines, and now they don't have to take COVID. I mean, what is the matter here? But the politicians, they dug their heels in, and so they caved. Now, most people in the military are younger and are not going to die from COVID, but it's not a good idea to do this. Remember those ships that got infected, and everybody was sick. I mean, this is not good for war preparation. That's why they have to take so many other vaccines. Regardless, this is the first big municipal mandate to go down. And, they fired 1,780 city workers because they wouldn't comply with the mandate. Now, they have hundreds of thousands of workers, all right? So it was a very small thing. And the unions, the police and fire union, were supporting them, all right? And also, a New York State judge reinstated 16 sanitation workers who did not comply with the mandate, and came up with a very strict ruling saying, that the order violated the New York Constitution separation of powers doctrine, was arbitrary, capricious, and violated the fire workers' equal protection and due process rights. I mean, this is ridiculous, but regardless, you have judges making public health decisions. This is not necessarily good. But anyway, what is happening now is, behind the scenes, the city of New York has stated that those people that were fired can reapply, and if the position is open, they will be considered. The unions are pushing that not only do they have to be taken back immediately, but they have to be given back pay. So it's going to be a really turbulent time as these mandates are lifted. And I think after May 11th, when the public health emergency ends, it'll be interesting to see what happens with the other mandates. Some of the unions are very pro-vaccine, and they don't want anybody working. They don't want to be in a pool that's got all these unvaccinated people, because COVID's not going away. It's just gone down, and then it's going to peak up again. So it's going to be interesting to see what really takes place. But it's a huge. This is going to have a huge impact, and I think at some particular point, if the cases stay down. Now remember, 100 people a day die from the flu, and we're talking here 450. And at the best, it was around 300. So something that's 3 times as bad as the flu. Do you want to get that? Do you want to put yourself at risk and put other people at risk, especially immunocompromised people? I mean, a lot of city workers and a lot of people in different job placements may have an underlying disease that puts them at risk. And remember, for COVID, the underlying disease is something as simple as adult onset diabetes, high blood pressure. There's many other conditions that put you at higher risk. So who wants that risk? You really don't need it. And that's what these vaccines are really good for. So anyway, it's going to be an exciting time.
Yeah, no, absolutely. And going into our last COVID headline, and this ties into a little bit of our statistics, but the viral threat is easing, but US hospitalizations are still as full as ever. So talk to us about what it means that cases are going down, but hospitalizations are still at like this constant high.
Well, we are at a point where these respiratory infections, which had been suppressed when we had a lot of mitigations, all the social distancing and mask mandates and wearing and all that stuff, that lowered all the respiratory infections. So when those restrictions were removed and people started interacting more, they came back with a vengeance. And so, we're getting a huge number of flu cases and respiratory syncytial virus, which is now easy to detect. It's been around forever, but we never used to detect it, but now we can. And I think you're going to see in the future that, you'll find, like, I have a cold right now. My COVID test is negative. I don't have the flu. But I probably have rhinovirus or something like that. That's not as easy to test. I can get it tested, but if it's just a flu, if it's just this cold thing, why bother? There's going to be, that's what's happening. And that's why the hospitals are full. They're getting all these other respiratory infections. And, particularly if they have underlying lung disease or they're a smoker, chronic obstructive pulmonary disease, or any other issue with their lungs, they are at a huge risk, and diabetes and other medical problems. And so that's why the hospitals are so full. They're not at total capacity, but they're up there. In Massachusetts, they were saying there were lines of people waiting for room in the ER. And as of Friday, 87% of all the available hospital beds in the entire state of Massachusetts were being used. That's getting very close to total capacity. So it looks like they're handling it. But, and as this whole respiratory wave goes down, into March and April, we typically see a big drop off there. And so things will sort of get back a little bit more to normal, whatever normal is, but it'll be less.
Yeah, no, absolutely. And then going into our first and only viewer submitted question, Dr. Murphy, can you tell us a bit about rapid tests, and are they still working, and
Yeah,
should we still continue to use them?
yeah, the rapid tests work great, but they're not as good as PCR. So if you just go buy one of the rapid tests in the pharmacy, or you get it free from your insurance, and I would advise everybody to stock up on these tests, because that's all going to end on May 11th. It'll be a free-for-all. Some insurers will pay, some won't, whatever. But you can stock up before then. And they do work, but you have to do more than one of them. They're not that great. So if you do one and it's negative, like some of the data that quoted in this article here, it's 60% accurate on the first day of your infection. So that's 40% with symptoms. It's going to be negative. However, if they didn't have any symptoms, it was only 12% accurate. Like they just went, I want to get a test. Maybe they had been exposed to somebody. However, if you do another test 48 hours later, it goes up to 92%. So you have to do them sequentially. You got to get one, wait 48 hours and get another one, or do them every day, whatever. Just do a couple of them and to determine whether you have COVID or not.
Well, wonderful. Well, thank you, Dr. Murphy, and we will see you next week.
Yeah, see you next week. Thanks, Sophie.